Hello, everyone. My name is Kenny Lee, Transitional Year Intern, and today my presentation will be on microscopic hematuria. Before we start, I think it's important to address that hematuria comes in two types. There is microscopic and there is macroscopic hematuria, which is also known as gross hematuria. And by definition, microscopic hematuria is when you have 3 or more red blood cells on urine analysis, while for gross hematuria, you would see blood in the urine with your naked eye. This PowerPoint was made with guidelines from the American Urological Association, also known as the AUA. So as a heads up, there may be some discrepancies from other guidelines. Before we begin, I think it's important to quickly go over the related anatomy. So in the urinary system, you have the kidneys that will filter the blood and produce urine. Then the ureter will transport the urine from the kidney to the bladder. The bladder will store and empty the urine, and the urethra will allow the urine to exit the body. So overall, in urology, we divide this into two systems, the upper and the lower urinary tract. And the upper urinary tract consisting of the kidneys and the ureters, while the lower urinary tract consists of the bladder and the urethra. To go more in detail for the urethra, so first, females. The urethra is really divided into proximal and the distal urethra. Well, for the male, it's a little more complicated. The posterior urethra starts after, at the bladder neck, then the prostatic urethra, and then the membranous urethra. And then begins the anterior urethra, which will consist of the bulbar urethra, penile urethra, and the urethromeatus. We address the anatomy here because how we evaluate the upper and the lower urinary tracts are very different during the hematuria workup. Let's say we have a case. We have a 45-year-old active duty healthy male presenting with urinary frequency, urgency, and nocturia for about 3 days. Otherwise, he's a healthy male, he's not on any medication, he never had a surgery, he's not seeing a doctor for any conditions. In family medical history, he says that his father was diagnosed with prostate cancer at age of 80 years old. And social, it's really just remarkable for smoking 40-pack years. So given this, what's your immediate differential? Can you come up with at least 5? Let's take a quick minute here. For objective findings, his vitals, he's afebrile. Other vitals are within normal limits. For labs, UA is just notable for positive blood, 4 white blood cells, 50 red blood cells, and 1 episquamous cell. Urine culture has been ordered, but the results are pending. And you don't have any imaging, and none were ordered. Given all this information, did your differential change with the objective findings? Is any particular differential higher or lower on the list? Let's take another minute here and maybe pause for a discussion. I'm sure everyone had a great differential, but a great mnemonic in approaching hematuria differential is something called PP on this with four T's. The first P stands for pseudohematuria, or a period. Second P would be prostate-related issues. For on, maybe there was an obstruction along the urinary tract. And maybe some nephritis, some intrinsic renal issue going on. And the four T's are for trauma, tumor, tuberculosis, really extra manifestation of the lung tuberculosis infection, thrombosis, maybe in the renal artery or the vein, and something hematologic or infection inflammation, and stones, of course, which are very common. And we'll go into more detail in the next slides. When we say pseudohematuria, we're questioning the source of this blood. Is it really from within the urinary system, or is it from the outside the urinary system? If it's outside the urinary system, it could be a multitude of factors. Maybe it's, inflammation from phimosis or balanitis, or maybe it's rhabdomyolysis, or if it's cyclic in nature, maybe, in females at least, maybe the urine is contaminated by the vaginal menstrual blood. Or if it is true cyclic hematuria, that could possibly from endometriosis of the urinary tract, or maybe there's a fistula between the urinary tract and the uterus. So, importantly, really, you just want to make sure that the urine sample was obtained correctly, which would mean, urine's freshly voided, it's either clean caught midstream, or it's freshly catheterized. If the male patient is uncircumcised, they should retract the foreskin, while for female patients, they should spread their labia when they provide a specimen. When we say prostate-related issues, prostatitis would be inflammation of the prostate, and depending on the patient's age, you can kind of narrow down the suspects. So for younger patients, usually less than 35 years old, you would suspect STIs such as gonorrhea or chlamydia. While for older patients, you would suspect more like gram-negative organisms such as E. coli, which could be responsible for up to 88% of the time, or other organisms such as Proteus or Pseudomonas. For BPH, the idea is that the prostate is enlarged and hypervascularized, so it's friable, and these vessels can be easily disrupted even with physical activity. While I guess for both prostate cancer and BPH, you want to also really consider their urologic history, such as maybe they recently underwent instrumentation of their prostate, such as prostate needle biopsy for prostate cancer workup, or maybe they had a cystoscopy for BPH workup. So getting a good surgical history is very important. This slide is pretty vague as, this has a lot of overlaps with the other components of the PP on this mnemonic. So, when we think ureters, the intraluminal space of the ureter is very tiny as the average diameter is only like 7 millimeters. So, this small lumen can be easily blocked with calculi, clots, tumors, or sloughed papilla. For nephritis, right? Intrinsic renal pathologies. When we think, glomerulonephritis, you're thinking red blood cell casts, while for interstitial nephritis, you're thinking really white blood cell casts. But the idea here is that the hematuria here is really classified by the, it's nephrologic in origin. So at the end, you ultimately want to refer to nephrology for further evaluation and treatment, but you still want to complete the urological evaluation for hematuria here with the workup that we'll talk later with the risk stratification slide. Here we start with the first T for trauma. You suspect traumatic hematuria if any of the following requirements are met. You either see an episode of grossly visible blood in the urine, or there is history of penetrating trauma, or the patient is a pediatric patient who is less than 16 years old, or the UA is showing over 50 red blood cells. Even if there was no episode of gross hematuria, if the mechanism of injury does suggest that there has been trauma to the GU system, such as, rapid acceleration or flank trauma, then this must be evaluated promptly. And some, signs and symptoms suggestive of a urethral injury may include blood at the urethral meatus, or they have a hematoma in their genital area or the perineal area, or they had penile fracture. With penile fractures, the history is really, during sexual intercourse, the male patient felt a pop followed by a immediate detumescence of their penis, and their penis is then really described as eggplant-like. Or the patient also has inability to void, or their bladder is very distended. These patients will be ultimately evaluated with the retrograde urethrogram, also known as RUG. In RUG, the x-rays are taken at an oblique angle to really visualize the entire length of the urethra. So if you think about it, if you just do a straight shoot and take it, anterior, posterior, the urethra, it loops down first and then upwards. So there's going to be some overlap between the parts of the interior and the posterior urethra. So essentially, during a RUG, you first take a scout image and then continue taking images as you retrogradely inject a water-soluble contrast. And so here, we'll do a fun exercise. Take a look at this RUG. Does this appear to be normal or abnormal, and why? We'll take a minute here. This is actually a normal retrograde urethrogram. So the urethral meatus here is not very well visualized, but let's start from the tip of the letter A. You see contrast going, in a retrograde fashion from the penile urethra, then to the bulbar urethra. Then a white arrow describes where the membranous urethra is, but you don't see any contrast here. That's because the membranous urethra is the external urethral sphincter, and it's shut tight here. And then you see the prostatic urethra and the bladder. Our second T is for tumor. Microhematuria is prevalent up to 31% of urine specimens, and the incidence of GU malignancy in these patients with microscopic hematuria is less than 1%. It's tiny, but the idea is that you want to work up as early as possible and rule this out. So in the upper urinary tract, you can have a renal or a ureteral neoplasm. And then in the lower urinary tract, you can have bladder cancer, which may have potential bladder muscle component, which will require a cystectomy, or maybe they have urethral cancer. So the whole workup for hematuria is really, you want to rule out GU malignancy if you're suspecting this, so they can stage and give appropriate treatment as fast as possible. For GU tuberculosis, you have the patient has chronic pulmonary tuberculosis that's latent, and then it spreads hematogenously to the urinary tract or the genitalia. And usually the diagnosis is really delayed due to signs and symptoms from other conditions such as urinary tract infection. Only up to 45% of TB cases have extrapulmonary manifestations, and of those, 30 to 40% of those cases involve the urogenital tract. But this data is really mostly from developing countries. As the incidence of tuberculosis in the United States, it's at a rate of 3 cases per million, and this was in 2013. And it's still to this day, it's probably very unlikely. And in developing countries, the most common extrapulmonary tuberculosis would be in the lymph nodes and then GU. So it's something you should consider, but it's probably very unlikely. And on imaging, you would probably see some calcification, multiple strictures, and fibrosis. For renal vein thrombosis, it's really more common in newborns and adults. So in newborns, the incidence is about 2.2 cases per 100,000 live births, but there's very scarce data to determine prevalence among adults in the United States. Pathogenesis, like for any other thrombosis, is the Virchow's triad, which is vascular endothelial injury, stasis of blood flow, and hypercoagulability. If it's acute renal vein thrombosis, the patient will probably present with symptoms of, renal infarction, which could be, flank pain, or their flank is tender, or their renal functions rapidly deteriorating, or they have worsening proteinuria, or they have micro or macroscopic hematuria. If it's chronic renal vein thrombosis, it's probably insidious in onset and the patient's asymptomatic. Patients with this condition usually has other conditions such as nephrotic syndrome, primary hypercoagulability disorders, malignant renal tumors, extrinsic compression, infections, trauma, or they recently had a renal transplant and with a complication. And almost two-thirds of those patients have bilateral renal vein involvement. For these patients, the workup would be CT angiography, or you can also do a uh, magnetic resonance venography or also MR venography. When we say hematologic, we're getting at, maybe the patient's taking anticoags such as heparin, warfarin, or they have a bleeding disorder, or they have sickle cell disease. Hematuria presumed from anticoagulants are not considered to be benign. So whether they're on anticoags or not, they must undergo the same hematuria evaluation, even when it simply occurs in setting of excessive anticoagulation. So never assume that the hematuria was caused by the warfarin or heparin or other anticoagulants. For UTIs and inflammation, again, there are some overlaps with the other sections. As we discussed prostatitis earlier, which could be chlamydia, gonorrhea, or E. coli based on the patient's age. Um, if the patient's having pain or burning with urination, or if they have other risk factors, such as they're older or they're female, or they have a history of UTIs after sexual intercourse, definitely get urine culture and treat with antibiotics. And finally, last but not least, you have stones. And this would be the most, probably one of the more common differential for a hematuria. And up here, I listed the 5 most common stones, which are calcium oxalate, uric acid, struvite, calcium phosphate, and cysteine. 90% of these stones are radiopaque, so you would evaluate with a CT stone, which would be without contrast. These patients should be counseled to, first, always drink enough fluids that will produce at least 2.5 liters of urine every day, or low sodium diet of less than 2,300 milligrams per day, to be on a low oxalate diet, and to take moderate calcium intake of 1,000 to 1,200 milligrams per day, as both ends of the spectrum, so too high or too low levels of calcium may actually increase the risk of stone formation. To have high fiber diet, if they're obese, then you would counsel them on weight loss, and to avoid high doses of vitamin C, which would be over 500 milligrams. These patients should they should follow the counseling and strain their urine for 6 weeks. If this doesn't work, they should be seen in the urology stone clinic, which happens on every Monday at the Madigan. PP on this mnemonic, it's not, it doesn't include everything. So for instance, there could be other etiologies. Maybe, they're taking a certain drug. And here is a laundry list of medications that's also listed on the AUA website. So for drugs, so phenazopyridine is also known as azo dye to relieve pain, burning, or discomfort in the urinary tract. And this dye can darken the urine into either orange or red color. And here you also see malarial drugs such as quinine and chloroquine, tuberculosis medications such as rifampin, antibiotics to include nitrofurantoin, and seizure medications such as phenytoin. So also look at their medication list as well. In our initial patient presentation, the UA was already ordered, but I just really wanted to emphasize on this slide that you have to order UA with microscopic analysis. even if the UA is positive for blood, but that positive heme on dipstick doesn't mean anything because etiology wise, is it true hematuria or is it just lysis of red blood cells, which can happen when the urine specific gravity is less than 1.007? Or maybe it can be other etiologies such as myoglobinuria, hemoglobinuria, or their urine was contaminated with iodine. And also, even when one urine sample shows microhematuria, you may be tempted to really double check to see if it was true hematuria and trend with follow-up UAs, which may, the follow-up UAs may not have any evidence of microhematuria. The AUA guidelines recommend that you have to start the hematuria workup, although the follow-up UAs are unremarkable to ultimately decrease the chances of missing malignancy in the GU tract. So really, there's no need to confirm microhematuria. So going back to our patient, what do you want to do next? Do you want any more imaging? If so, what kind? Any workup you would consider? Let's take a couple minutes here and also discuss the other steps. The 2012 AUA guidelines defined hematuria, as you see on the far right column, simply as UA with at least 3 red blood cells. So all patients over age of 35 meeting this criteria would undergo cystoscopy to evaluate their lower urinary tract and CT urogram, also called CTU, to evaluate their upper urinary tract. However, this really made all these patients go through unnecessary radiation exposure and surgical intervention. So, in their 2020 guidelines, the AUA further risk stratified patients into low, intermediate, and high categories to determine the appropriate workup. So now patients are stratified based on how many red blood cells there are on their urine, their age, history of smoking, and pack years, and other additional risk factors, as you see as delineated right below the table as irritated voiding symptoms, chronic indwelling Foley catheter, pelvic radiation, chemotherapy, and on. So to be in the low category, they have to meet all the criteria. Red blood cells from 3 to 10. They're male who's under 40 years old or female who's less than 50 years old. And they smoked less than 10 pack years, no additional risk factors. And then you would do shared decision making with the patient for maybe just cystoscopy or just repeat the UA and see what they find. And then if you meet any of the intermediate criteria or at least one, then you would do cystoscopy for the lower urinary tract and the renal ultrasound, which is RUS, to evaluate the upper urinary tract. And then for high, same thing. If you meet any of the criteria there, you would then do the full workup, which would be cystoscopy and a CT urogram. Going back to our patient, our 45-year-old patient who had irritated voiding symptoms, 40 pack years, 50 red blood cells on UA, he met 3 out of the 4 criteria for high risk category. Thus, the recommended workup for him would be cystoscopy and CT urogram. To note, CT urogram is contraindicated in pregnant women,
patients with allergic reactions to contrast, such as anaphylaxis, or those with poor renal function. Then the second imaging modality you would go to evaluate the upper urinary tract would be a MRI urogram. But if the patient also has contraindications to a MRI urogram by having metal implants, then the third imaging modality would be a retrograde pyelogram with non-contrast axial imaging, so CT or MRI without contrast.
The purpose of this presentation was really to briefly go through the differential diagnoses of possible causes of hematuria in the next workup that a urologist would do. I really hope this helped a little bit, if not at all. And this concludes my presentation. Thank you.